Hi everyone and welcome to Doc Talk. We have a special guest on the show today, a medical oncologist all the way from Beverly Hills, California, and the former Vice Chief of Medicine of the Cedars-Sinai Medical Center, Philomena McAndrew. Dr. McAndrew is an alumni of the University of Pennsylvania, and among the many things that we'll discuss today is how she got interested in a career that involves taking care of cancer patients. Dr. McAndrew, welcome to the show.
Thank you so much.
It's a pleasure to have you here today.
Well, I appreciate you inviting me.
And one of the things I'm very excited and look forward to hearing your perspective on is the fact that you are revered and endeared by your patients. I read several blog posts, articles where patients had said that you really took the time to connect with them and build a relationship with them that helped them throughout the course of what could have been a brutal and draining cancer chemotherapy regimen. So could you please talk us through, what is the secret of this popularity?
I think that being a medical oncologist could be a very difficult thing, and many other physicians and people in other fields say, how could you do that? To me, connecting with the patients and being able to talk to them as people, as human beings, listening to their fears and trying to calm them down is such an important part, I think, of being a physician, and especially in a field where their fears are oftentimes, unfortunately, realized. So to me, the relationship is so important, to develop a warm relationship with the patient, with their family, having a group of people with you, that your nurses, nurse practitioners, the chemotherapy nurses, everyone, even from the receptionist at the front desk, making the patient feel comfortable, that they're there for them and they're supporting them. And to me, that has become what allows me to go forward every day and be happy to go to work and excited, and rather than fearful because of the stress that can happen.
That's really inspiring. But I imagine that for some of these patients, the outcome may not always be positive.
Yeah.
And in those circumstances, how do you prepare them and their families to embrace or at least be prepared for what is about to come?
It can be very difficult, and that's where also a team approach is so important. We as physicians are oftentimes afraid to talk to patients about their advance directive, about what their goals are and their wishes for the future, because we feel that that tells them that we're already writing them off, or that we don't think that they'll do well. And even patients that we know can't be cured, many of them either may live for many years or for some period of time with good quality of health. So we don't always want to bring up the specter, of death to them. But I think slowly becoming realistic, trying to understand what someone's actual goals are and how they would like to proceed if certain events occurred, is an important thing to do. I oftentimes will slowly try to enter into the conversation about it, have them meet with the social worker and the therapists. Our nurse practitioners talk to them, and the nurses also, connect with them in that way. It's very important, and I think medicine today is really gravitating towards that. It's become mandated that we, even on the electronic medical record, we have to put in an advance directive or advanced care planning. So we're being pushed to do that, but that's such an important thing, because we, at least when I went to medical school and did my training, we never really learned how to have that conversation with the patient. It's something that you had to evolve into by having made some missteps, making comments to people that you can't retract. So that's something that's important to remember, that when something's out there, you can't reel it back in. So you have to be very careful with how you tend to say things to patients, but honest. And to me, they don't always want to hear what we have to say, but doing it in a kind manner at the right time to be able to have them know that you're telling them something, but you also have to give them some hope. If that hope is, helping them to be comfortable, making sure that they've taken care of other arrangements, making sure that their family is there, making sure you're doing what to them is the most important thing as they evolve and potentially go to a different level.
Yeah, I think not much has changed in the sense that even today in medical education, we are not explicitly taught how to have these conversations. We have to slowly evolve ourselves into it. So thank you for sharing that. Another thing I'm excited to get your thoughts on is that you've, in your career, taken care of several well-known celebrities. A few that come to mind are Audrey Hepburn or Christina Applegate, but I'm sure there are plenty others. And in one of your interviews, you had said that sometimes for these celebrities, having a good doctor is very critical because physicians can be starstruck, and so their patients may not get the best care that they actually need. So how do you strike that balance of keeping the distance and not being starstruck?
It's hard to say. I think it has to be in your basic personality where you look at that individual as a patient, as a person with a problem, and as a human being, obviously, and not who they are on the big screen or in their position, whatever their position is in life. And when obviously, they have the same fears and anxieties about being diagnosed, especially in my field, with a malignancy. And having to be honest, because I have found that many physicians want to please someone who is a well-known celebrity in whatever field that they're in, and doesn't always tell them the honest truth about either what their problem is, what the potential outcomes. They don't always give them the advice that you would give to someone who is not in that position, so they may get worse care. And when I talk to people, I say, I know this is not going to be what you want to hear, but it's important that you know that, and certainly you have every option to make, not to take my advice, but I'm obligated to educate you about this, and people can choose not to or choose to do it.
Along the same lines of this obligation to educate, I saw an episode where you were on the Oprah Winfrey Show a few years ago. So I was curious to know what that experience was like.
That experience was an interesting experience. I actually had not planned to go and really was trying to help when I had gotten a call from the show that was requested by Christina Applegate, who was also going to be on the show, and she had wanted me to be on with her. Initially, I said there are plenty of physicians in Chicago. I gave them names of people there that they could have come on the show to talk about breast cancer and just cancer in general, and they wanted to discuss a little bit about inherited susceptibility. And when they insisted, I said, okay, well, and it was a 24-hour fly-in, fly-out, and be mic'd up and to talk to the audience. When they did have a live feed, and they had questions that were being asked by individuals that were calling in, Skyping remotely, and some of those were difficult because they were, one was a young woman who had metastatic breast cancer to the brain, and that was tough as she was asking questions, and to have that in such a forum, where millions of people were watching, was difficult.
I noticed that you are a Philly native. You went to Villanova for undergrad. You were at the University of Pennsylvania for medical school. Then you were at Temple for your residency. And then you moved to the West Coast, UCLA, for fellowship.
Yeah.
And you've been there since. Now Beverly Hills, California is, I believe, where your home is. So what led to this transition?
So I got married in first year college. So my husband and he was with me through, my senior year in high school. I took him to my high school prom. He was with me through medical school, internship residency, college medical school internship residency. And so we had always been in Philadelphia, and when I got to the level, and I had always only applied or seriously thought about education locally. But when it came to the fellowship, I just asked him if he was willing to have me cast the net out and look more broadly for that last level of my training, and he was certainly open to it. So we looked around, and I wanted a program, because there were many programs at that time were more heavily heme-based, some were oncology-based, and there were only a couple programs in the country that were doing bone marrow transplant. And so I was very interested at that point, not that I necessarily planned to do transplant, but wanted the experience, as broad an experience as I could get, to be able to see what was my area of interest. And so I was offered a fellowship at several places, fortunately, which I was very humbled by. And at that time, there wasn't a match for a fellowship. It was you would get offers from multiple centers. So, and he was willing to pick up, and we had planned that it would be for 3 years and then move back to Philadelphia. And we moved there, and we did enjoy it. For my husband, who's a builder, the work was good because it wasn't raining or snowing for 5 months out of the year where he couldn't work. So we then started our family there as well. So we remained there.
That's incredible.
Yeah.
Through many of your prior clinical and research efforts, it seemed to me that you had a special interest on metabolism and nutrition and its impact on cancer.
Mm-hmm.
So what are some of the recommendations or just takeaways that you drew from your work that you feel like could impact clinical care or just how we manage patients today?
Well, certainly, as we have recognized even in some of that work back then, but through multiple other studies with the Women's Interventional Nutrition Study that we were lucky to be a part of, that diet is so important, and it impacts on multiple cancers and a significant percentage of human disease. And that alcohol, cigarettes certainly, and just high-fat diets, or just in general obesity, have a great impact both from cardiovascular risk, cancer risk, and likely many others as well that I may not be. But those are the two major ones where I think that lifestyle changes impact greatly, on the development of those problems, and that taking measures to try to pull back time for that has made a great impact. We definitely have seen with breast cancer that reducing fat, and one of the studies that was done that has led to multiple other recognition of connections was that cutting back the fat in the diet, and it was all fat. It wasn't just it wasn't just the saturated fat, which we had been more involved with in terms of cardiac health, heart health. But all fats, when it came to cancer, it seemed that animal fats and non-animal fats were associated with an increased risk of cancer. So with that, with the results of that Women's Interventional Nutrition Study, the WIN study, 20 years ago, showed that a reduction in what the U.S. average fat in the diet was 40% at that time, and they tried to cut it to a 20%. And they were able to get it to about a 22%, so they weren't happy with the fact that they couldn't achieve their goal for the people, the intervention group, but they found that there was a 25% reduction in recurrence of breast cancer, which was as good as we could get with many drugs. So that was powerful to see that kind of an intervention, and that it was even more meaningful in patients who had estrogen and progesterone negative or hormone not responsive cancers, where we, after their initial surgery, chemotherapy, that they didn't have anything else that we could give them at that time. So that, and now evidence that certainly alcohol also can have an impact on recurrence of cancer. So, exercise also, 2.5 to 3.5 hours per week of moderate exercise has also caused a reduction in about 25% of recurrence of cancer, of breast cancer, at least those studies.
you're involved with several cancer-related charitable organizations. So what type of work, do you encourage or foster by being a part of such groups, and how important is that to your work?
So our group, so I'm in a 12-doctor oncology practice, and we actually built the practice from two of us initially, having a third doctor join us, and merging with a group of 4, and then building from that. And that's how we developed, Tower Hematology Oncology. And we're affiliated with Cedars-Sinai and have, also an academic affiliation with UCLA. We started what was called the Tower Cancer Research Foundation. And so the physicians we all donated to get this started, and then we've donated yearly since. And with, fundraisers and grateful patients, we were able to, have the core to be able to then start to give out funds. And what we did was we tried to say, what is the best way of using these funds? So some of it was to try to pay for research nurses, so that way we could offer trials that were, some of these were, were pharma trials, and some of them were multi-group trials, so that they were national trials that were being done and international trials, and that we were one of the sites investigating. And of course, when you do many of those trials, there is either no funding or very minimal funding, not enough to be able to get all the regulatory research nurses and everything else that has to be done to be able to cover the cost of that. And so we were able to use some of those funds for that. And then we also felt, though, that we wanted to be able to offer services to patients, in terms of exercise, in terms of psychosocial. And so that became part of that quest. And then the third aspect of it was to give back to do seed grants for young investigators, because, at that time, and even worse since, the amount of national funding and governmental funding and private funding has really been reduced significantly. And so the people who we were when we were in our training, and subsequently who have followed us, to be able to get the core grant to be able to start your research or your initial, bench research, that we felt it was really important to do that. So we did start out with giving a couple smaller grants, to fellows that were in local institutions, so UCLA, USC, City of Hope, and Cedars-Sinai, UC San Francisco, and UC San Diego. So it was really more of a regional, but we started getting applications then, and from year to year it's gotten to the point where we have, we've gotten 30, 40 applications, and some of these are amazing, work that's being done, and many of the people who have been granted those have gone on to be at faculty at City of Hope, at Sloan Kettering, MD Anderson, multiple institutions, UCLA, and really are the monies over the years, which have been about $6 million, have now catapulted to much more money in terms of being able to get them, giving them the core work that they needed to be able to get other governmental grants, et cetera. So that's been exciting.
So this next segment, Dr. McAndrew, is our rapid fire segment.
Oh boy. Okay.
So in this segment, I'll be asking you a series of questions, and your job is to respond with the first thought that comes to your mind.
Okay.
So are you ready?
Okay.
One thing about Philadelphia that you miss in LA?
The diversity that I understood when I was younger, which is different than today, plus the cheesesteak sandwiches.
One aspect of LA you think Philly should really embrace?
I haven't thought of that. That's an interesting thing. Certainly not the traffic, although it seems like they have, unfortunately.
Okay. One book that you've read recently that you would recommend our viewers to read?
Oh, The Gene by Siddhartha Mukherjee, which is amazing.
A life skill that you think most, if not all, medical oncologists have by virtue of seeing their patients?
I wish I could say there's a universal life skill. I think some of it is, as someone had mentioned, that sometimes oncologists are a little unrealistic because they always are a little bit more optimistic than we should be. But I think being optimistic may be a good thing. I'm not sure that that's true for all oncologists, but maybe.
Great. Well, thank you so much once
You're
again for
welcome.
being on the show today, Dr. McAndrew. Thank you all for watching. I hope you enjoyed this segment, and I'm sure our viewers benefited tremendously from your insights. So thank you for being on the show.
Thank you so much. It was my pleasure.